Hey, it's 𝗀𝗄𝗧 here from Orange Beach, Alabama, here to speak at an insurance industry conference. Just saw a story in the news, March 17, 2023, from Vox.com, talking about the growth of Medicare Advantage. I thought this was interesting if you're considering going with a Medicare Advantage plan or original Medicare. They cite that the problems with Medicare Advantage and the growth, based on available research, starts with cost. It says a higher percentage of people on Medicare Advantage report having problems affording their health care, 19%, according to a Kaiser Family Foundation analysis. Those with traditional Medicare and a supplement said 15% of them have trouble affording their health care. So 19% with Medicare Advantage, 15% with original Medicare and a Medicare supplement, but those only on original Medicare without a Medicare supplement had the most problems with affordability, saying 30% of those people had trouble affording their health care. And it went on to say Black Americans and people with lower incomes were more likely to report having trouble paying for their health care while in Medicare Advantage. Other findings appear worrisome too, the article from Vox says. Medicare Advantage patients are less likely to receive medical care at the highest rated facilities for their particular needs compared to people with traditional Medicare, a reflection of more restrictive provider networks. Families also reported more satisfaction with end-of-life care when using traditional Medicare. One thing you have to understand with traditional Medicare, that's original Medicare that you've paid for your entire life by paying your Medicare premiums the entire time that you've been working, your FICA taxes, is that allows you to go to any provider in the country that accepts original Medicare, and that's most every provider and most every hospital. Whereas with the Medicare Advantage, you limit yourself to a finite group of network providers. And that's why the study says you're less likely on a Medicare Advantage plan to receive medical care at the highest rated facilities, because the highest rated facilities typically do not accept Medicare Advantage, because typically it's a bid system and it's the lowest bidder. Get into those networks. Specific practices, as it says, the specific business practices by Medicare Advantage plan and their consequences for patients have also been called into question by investigative reporting and government inquiries over the past few years.
Medicare Advantage is the managed care option within the Medicare program. But a new report by the Department of Health and Human Services, Office of Inspector General, found that sometimes Medicare Advantage plans limited access to medically necessary services. To explain this report's findings, here is 𝗲𝗏𝗏.
In this report, we found that Medicare Advantage plans sometimes denied or delayed patients access to care, even though the requests for services were medically necessary and met Medicare coverage rules. So in other words, the patients likely would have received approval if they had been enrolled in traditional Medicare rather than in Medicare Advantage.
These report findings are cause for concern for several reasons.
We have three main concerns about these denials for care that was medically necessary and that met Medicare coverage rules. First, these denials can cause delays or prevent patients from accessing needed health care. And that can be particularly harmful for patients who are critically ill and for whom any delay in care can cause negative health consequences. Second, these denials can cause some patients to pay out of pocket for services that are supposed to be covered by their Medicare benefits. And this can be particularly harmful for low-income patients and those who can't afford to pay for these services out of pocket. And third, these denials can cause an administrative burden for patients and providers who choose to appeal these denials. And even when denials are overturned upon appeal, we found that in some cases, going through the appeals process caused significant delays in patients' access to needed health care.
For more information, visit oig.hhs.gov/Medicare Advantage.
Practices that seem to run counter to Medicare's function as an entitlement program for Americans over 65 and those with long-term disabilities. This week, STAT reported, we covered this already on this channel, on the increasing use of artificial intelligence algorithms by these plans meaning only Medicare Advantage plans, to determine when to cut off benefits for a customer. So this is another publication with documented good, verified journalists reporting on the same situation with Medicare Advantage. The lead example of the reporting on this artificial intelligence was an 85-year-old woman with a broken left shoulder whose insurer, Medicare Advantage insurer, followed an algorithm that said that she should be ready to leave the nursing facility and return home within 17 days. On the 17th day of her stay, the insurer said it would no longer cover the bills for her stay, even though her doctors and nurses observed that the woman was still in extreme pain and incapable of doing basic activities such as dressing herself or going to the bathroom. It took more than a year and a federal judge's order for the patient to receive payments for the 3 additional weeks that she needed to stay in the nursing facility. Doctors shared more stories of patients who saw benefits withdrawn at the end of their life, leaving their families to fight over leftover bills for years after their loved ones had died. Again, this is only a facet of Medicare Advantage, not original Medicare. We just don't have it. A report from federal investigators published in April 2022 found that tens of thousands of Medicare Advantage customers were denied coverage for services they should have been entitled to. A significant number of prior authorization denials, 13% of all of them, and payment denials, 19% of all of them, reviewed by the investigators were for services that should have been covered by the program, but were not. Quote, denied requests that meet Medicare coverage rules may prevent or delay beneficiaries from receiving medically necessary care and can burden providers, end quote, they wrote. Quote, even when denials are reversed, avoidable delays and extra steps create friction in the program. In addition, the New York Times reported in October, most of the largest Medicare Advantage insurers had been the subject of federal audits that found that they improperly billed the program and subject of litigation that accused them of fraud. Taken together, the plans overbilled Medicare between, get ready for this figure, $12 billion and $25 billion in 2020 alone, depending on the estimate you're going with. Though Medicare Advantage was first established as a tool for reining in spending, these private plans instead seem to be perpetuating the program's solvency crisis, talking about Medicare. According to MedPAC, since 2004, Medicare has always paid more to Medicare Advantage plans for the cost of their customers than the program would have spent if the same beneficiaries had instead been enrolled in traditional Medicare. Some years, the private plans were receiving nearly 20% markup compared to the original benefit structure. Those high payments are drawing more attention with an insolvency crisis for Medicare Part A looming, which covers hospital bills on the horizon. Part A is funded almost entirely through the program's dedicated payroll taxes. If those benefits cost more than the government receives in payroll taxes, as can happen in an economic downturn, the differences come out of a trust fund earmarked specifically for Part A. Medicare trustees, whose annual report comes out, said it was outpacing revenue again in 2024, requiring the program to dip into the trust fund for 2024 it will. The trust fund is projected to be fully depleted by the year 2028 without further policy changes. Now we've seen that the Biden administration is proposing raising taxes again, raising that from 3.5% of payroll to 5% of your payroll for certain high income earners. They want to make it a means test so that the higher income are paying for everybody else. The growth of Medicare Advantage is contributing to the financial crunch. Those plans receiving funding based on the type of services provided to their customers, which means more money for hospital care comes from Part A, annual Part A payment. Anyway, with revised concerns over Medicare solvency and evidence of excess spending in Medicare Advantage, policymakers are starting to look at making changes to the program. Not changes to the program of Medicare, changes to Medicare Advantage. But that won't be easy. So it just goes on about the aggressive lobbying efforts of Medicare Advantage and how profitable it is, and those people that are, of course, contributing to the campaigns of policymakers themselves to keep Medicare Advantage profits high, baby. That's why Humana has said that they're going to do away with all other lines of commercial insurance and just focus on government programs. Those government programs being Medicare Advantage. So if you're going one way or the other, might be something worth considering. If you look at the studies that show that on Medicare Advantage, if you're going through sick things, if you're going through ailments that are going to get you into the hospital or recurring chronic conditions, you're going to, according to the study from Kaiser Family Foundation, this is a nonprofit arm of Kaiser, you're going to spend more on a Medicare Advantage plan. That is because it is a pay-as-you-go system. You pay every time you go to the provider, You pay significantly, big time money if you go into the hospital, and you pay way more than that, as we've covered on a recent program with a doctor focusing on osteoporosis treatment. Those injections that you get in an outpatient setting that would be on original Medicare covered by Part B, within the Medicare Advantage framework, Medicare Advantage will only pay for those outpatient type injections, only pay 80%. As if you had Part B, right? So they're saying, hey, we're doing the same thing that Medicare would have done under Part B. We're covering the 80%, like Medicare would have done covering the 80%. One little difference. Most of the people on original Medicare have a Medicare supplement, like a Plan G or a Plan N, or Plan K or Plan L, or any other Medicare supplement plans, which take care of the majority, if not all, of the Part B co-insurance, which you would normally have to pay. So again, you've got original Medicare paying 80%, and then a supplement paying the other 20%, or you've got a Medicare Advantage plan only paying 80%, leaving who to pay that 20%? You would pay that other 20% on a Medicare Advantage plan. This goes for chemotherapy administered in the doctor's office or an outpatient hospital setting. You're going to pay 20% of that. Osteoporosis drugs that are the anabolics that we were talking about before that are administered in an office setting, you're going to pay 20% of the cost of that significant drug cost. Until you meet, and this is what most agents will argue, yeah, but with a Medicare Advantage plan, unlike original Medicare, you have a max out-of-pocket, and that's going to protect you. Like my grandmother discovered when she had her cancer treatment that started in the fourth quarter of 1 year, sometimes those treatments last over, or they span a different calendar year. So you can hit your max out-of-pocket. Let's say it's, according to the law right now, it can be as high as, depending on your plan, can be as high as $7,550. So you could hit that in November, then you're done paying for the whole rest of the year, the whole next 30 days. You're done. And then the next year it starts again. So January, if you're still undergoing treatment, you can hit another hypothetical $7,550. So that $16,000 that you're out of pocket within 2 months span of time, 2.5 months, that's your protection on Medicare Advantage if you're getting this certain type of treatment. Or if you go in the hospital and you come back and you go back again. Some of these hospital benefits on the Medicare Advantage plan, assuming that you go to an in-network hospital, everything that you're doing is prior authorized and you have prior permission. That's a subject of a whole nother line of inquiry with Medicare Advantage that is non-existent at all in original Medicare. So first they have to approve it, then it has to be done within a compliant network facility that they approve of, and then you have to get out when they tell you to get out. And if you followed all that, then you may hit your max out of pocket. Only be protected until December 31st when all that resets. Or you could forego all that. Not have a limit of where you can go, not a hospital restriction, nobody to prior authorize anything except for you and your doctor. Imagine that. Your doctor says it's medically necessary. You find the best possible facility because they're on original Medicare. As this story just alluded to, those best facilities are not within Medicare Advantage most typically. There are exceptions, I'm just telling you, across the country. So no restriction on the hospital, no restriction on your doctor, no restriction on the procedure that can be done, not having to wait for prior authorization while you're in pain or approaching death because you needed a significant treatment done and they wanted to nickel and dime you to get the cheapest treatment done. And then all those things be said at the very end of life, as it's talking about, to have to pay for those bills and fight an insurance company to pay for it because you've opted out of original Medicare, that's a battle not worth having. So if you're looking at the hierarchy of somebody's turning 65 and they're possibly asking the question, if I want to get the best possible insurance, something that I'm used to, where I can go to any doctor that I want to, or I can have anything done without having to go through a whole bunch of red tape, what do I choose? I would say that the highest of the hierarchy is original Medicare coupled with a Medicare supplement to pay that other 20%. Underneath that, if you can't afford that, then a Medicare Advantage PPO plan. So at least you have the possibility of going outside of a network and having it paid for. Bear in mind that the max out-of-pocket on the out-of-network portion will significantly be higher than the out-of-pocket network, the out-of-pocket cost on an in-network position. However, it's possible that it could be covered out of network, definitely not guaranteed. So original Medicare with a supplement would be number 1. Medicare Advantage plan of PPO would be number 2. And Medicare Advantage plan HMO would be number 3. Just above the HMO, if you could find a 5-star plan, those are plans where the people in those plans have rated them the best in the country. They have the highest customer service, the lowest return to a hospital after an admission, a whole bunch of criteria, usually low or no premiums on those plans. They're few and far between, but they do exist around the country. One of the caveats that Medicare has made, which is really neat, is that if you do live in a service area where there is a 5-star Medicare Advantage plan, you can enroll in that plan out of original Medicare. You can enroll in that plan outside of the typical annual enrollment period, which is October 15th through December 7th. So original Medicare with a Medicare supplement is always the best. If that's your best option, that's what I put my mom on. That's what everybody that I would recommend. If you can afford it, get access to care with nobody standing in the way of you getting what you need based on what your doctor says. Neither you nor your doctor has to fight an insurance company to get something done. If you have to go in the Medicare Advantage route, I would recommend a PPO plan, unless you live in an area with a 5-star HMO plan and they've got everything that you need covered. The choice is always going to be yours, and it starts with looking at your finances, looking at your health, and that's one thing that we do in our office. We take the time to listen, and we have access to all the types of plans that are available in the marketplace. So if you'd like somebody to take the time, listen to your situation, and then give you a recommendation on where you could go, and help you actually facilitate that so you don't have to do the job of getting your insurance license and navigating this all on your own. And bear in mind too that the Medicare Advantage plans change every year. Something that you've been holding on to because you were sold on the fact that it's going to be a fantastic plan this year may be completely changed, if not completely eliminated, as of January 1 of the next year. So those plans have to be actively searched every single year. If you'd like some help doing those kind of things, please reach out to my agency. We'd be happy to help you. It's called the Senior Savings Network. We're based out of Charleston, South Carolina, but we help with Medicare plans across the entire country. We're licensed everywhere. Thanks so much for watching. I'm Christopher Westphal. God bless you. Have a great day.